Hi, it's Marvin Schlossman, CEO of InspireMD, and just wanted to open up an interesting conversation since we're all in New York City for the V Symposium. We had an opportunity to revisit our original KOL event, which took place in March of this year, and we've actually added a couple of esteemed guests to the forum for this evening's discussion. But the folks that you recognize are obviously Dr. Chris Metzger from Valid Health System in Kingsport, Tennessee, Dr. Sean Lydon from the Cleveland Clinic, and our newest guest all the way from Rome is Dr. Tommaso Castrucci, vascular surgeon from Rome. We're going to have a couple of additional people dial in, including hopefully Dr. Adnan Siddiqui, who was on the last call. He's currently in surgery. But we felt like this would be a good opportunity for us to revisit some of the topics that we discussed back in March. The carotid space continues to evolve and unfold, and thought that it might be a good opportunity to hear from those that participate every day in the space to give some perspectives in terms of what we should expect, some things that are changing, some expectations from a practitioner's point of view and a physician's perspective. So why don't we start with this, guys? It would be great to revisit the discussion from March. Obviously, things are evolving as it relates to treatments of carotid disease. I think most importantly, when we last talked, there was some momentum toward reimbursement, but also some changes in the way technology platforms are evolving, endovascular solutions seem to be beginning to catch momentum after a number of years of some stagnation. So maybe just take a couple of minutes and give your perspectives of what you're seeing and hearing, and of course on the back of the V Symposium, where the most current data and technology is being presented.
I'll be happy to start. So I think since then, we continue to see, Sean and I have been honored to be on a multi-society carotid alliance. The idea is getting all specialties together and petitioning CMS for what really should have been done years ago, that this should be reimbursed. And we've seen that they've already acted for TCAR, for getting standard low-risk patients approved for that. And I think now, even since our last meeting, there's been more evidence that comes out that just suggests we're there now. We have a SPACE 2 and we have ACST 2, both again showing equivalency of carotid stenting to carotid endarterectomy, which, as we all know, has been reimbursed for a long time. So you couple now 5 randomized trials showing equivalency, long-term data, 10-year crest that shows that they're both outstanding, endarterectomy and stenting. Act 1, 5-year, outstanding. ACST 2, 5 years, equivalency, outstanding. Couple that with 50 or 60,000 registry carefully adjudicated patients. I think that now the consensus is they asked us to put a paper in JACC, a white paper, together with the state of the art of carotid stenting, which several of us were on that paper. That's been published just like they asked. So I think we're in a good spot. In fact, I personally don't see how they could not approve a technology with so much data in favor of it. So I think we're in a good spot, and a lot of us have waited a long time for this, some even longer than others. So great. That would be Chris's take.
So before Dr. Lydon answers, just wanted to quickly introduce the late member to the crew here, but an important part of our KOL board and group, Dr. Kenny Rosenfield from Mass General, who's joining us today. So we're, again, trying to expand the original group to get different perspectives. One of the things that we love about being able to put this multidisciplinary group together is the focus on carotids obviously goes way beyond one subspecialty. So we're really thrilled to have a really diverse group, both internationally as well as subspecialty. So the question, Dr. Rosenfield, was, from our last KOL discussion, what have you observed? What's changing? Obviously, the carotid space is moving forward in a lot of different ways. And I just wanted a general idea of your perspectives, especially on the heels of the V Symposium and the latest data.
So, I would agree with Chris. We were able to put out a white paper that shows we have a pretty good idea of a lesion that might be treated surgically, might be treated with TCAR, might be treated transfemoral, or it might be treated well with all 3 modalities. And so really the official submission is in to CMS to ask them to reconsider the NCD. And really it's to try and put this therapy back in physicians' hands. So We know that carotid therapy works, whether it's surgery or stenting, whether it's transfemoral or transcarotid. We know through 10 years, the data shows are equivalent therapies. Nobody concerns anymore of the durability of carotid stents. We've proven they can all be done safely. And it's really the ask to CMS is to say to let physicians decide how best to use it, to have informed discussions with the patient, medical management versus all the options, and then really to customize it based on local expertise, training, and just like every other thing we do in medicine, to have how it's adjudicated, how it's credentialed up to the hospital credentialing committee. And, those hospital credentialing committees tend to use societal guidelines in terms of how someone becomes credentialed to do this. And I think we've really seen, from that white paper putting out there, just a summary of where the data set is. If we look at the last time the NCD was looked at back in 2009 and 2010, the big ask that CMS said was there was no late data. And now there is an abundance of late data. And along that lines, we've seen TCAR using the VQI data show that in low risk patients, it's done very well, despite the fact the registry was supposed to be high risk patients, and now seeing the broadening of coverage to do it. So I think, we're seeing investment in the space. We're seeing, besides what we're seeing with InspireMD, there's Contigo Medical having new devices. And I think there's a lot more interest because, finally, I will not have to have the awkward discussion to a patient of what I think's best, as opposed to looking down to see what their insurance is. And I can just do what I feel is appropriate for the patients.
Great. So let's take that a step further in terms of your decision of treatment, assuming that this NCD is approved and standard risk becomes more ubiquitous in the space overall. How does that change the practice? How does it change your ability to do more endovascular procedures and just the dynamics of what the money flow means in terms of the way the market.
So maybe I think the surgeon should comment first, because, when carotid stenting trials happen in the United States at the Cleveland Clinic, I've been there 21 years, we were doing 500 carotid stents a year. And, I'm a surgeon, but it was never a difficult discussion with a patient. Do you want an incision or do you want a puncture? And so when therapy is reimbursed by skill and it's up to the clinician, if I have someone I think you can do well either way, I think that we'll see a rise in the overall therapy of number of patients treated. I think we'll see a rise in transfemoral. I think we'll see probably a little dip in TCAR, and we'll see a probably big dip in surgical therapy, just because if you can give a patient a choice either way, I mean, I'm a surgeon. If I can have equivalent outcomes and I can have puncture, I'd have that over surgery. And you have much quicker recovery and the outcomes are equivalent. And so I think it'll come back to the days where, now we're 90% endodorectomy, 10% stenting. It'll go back to the days where it was 90% stenting and 10% endodorectomy at my institution.
Well, that's the way I choose the therapy for my patients. I mean, I'm a surgeon. I can do all three of them, actually, not TCAR with the commercially available device, but off-the-shelf device. And I try to customize it on the patient I've got. If he prefers a traditional surgery, some patients do ask for traditional surgery, even though they ask for it because reading literature, something in our guidelines, in Italian guidelines, stenting is considered as least as efficient as surgery. And in my language, that means better. But it's always, surgery is always the gold standard. So probably patients who read literature stop at that line and say, I want to, otherwise it's who shouldn't have a stent, who shouldn't have surgery, and the great bulk of the patients can choose what they want on the basis of my experience and their preferences. I think that's where the market should go.
Great. Go ahead,
I was
Chris.
just going to say, it's been on this pause, as you talked about, for probably for 20 years. And now, for investors on the call, the excitement in my mind is I think that pause is going to be lifted. Right. And then the strategies that are effective and have evidence to support their effectiveness are now going to be much more potentially valuable and needed. Not just valuable for the individual companies, but for other bigger companies who may not have that they've paused their investment for 20 years. And now those that are ready, when the decision comes out, will be well positioned. And so I think that with the excitement of the newer devices, the trials that are coming out, it's gonna be, you want to be well positioned when the decision comes out. And if you're not well positioned, what you could do is be in a 2 or 3 or 4 or 5 year waiting period. As you know very well, as everybody in the room knows, how long it takes to design a trial,
Right.
go through the FDA, run the trial, get the 1 year follow, whatever it is. I think this is an exciting time to have a good technology ready to go.
So great segue. Thanks for the feedback on the market. At InspireMD, obviously, we've placed a very big bet on this market, and we're betting on the momentum that you guys just described, both from a market point of view, the economics matter in a big way, but it is about having the right technology at the right time. We believe that rising tides benefit the industry as a whole.
Yep.
But obviously with Seaguard, and you all have had a fair amount of experience there, selfishly, we see ourselves as optimally positioned here. We're a singularly focused company. Let's talk a little bit about our strategy related to outcomes and data and stent technology as it relates to patient care, as opposed to delivery system narrative that seems to be a part of the theme of the discussion in the industry as a whole. Our bet that we're placing is really on the stent, on Seaguard, on outcomes, and on data. The numbers do matter. 1.12% complication rate as compared to either surgery or first generation stents. It's big, as you said in one of your discussions at the podium, which I liked. It may not seem like a big difference between 6% and 1% unless you happen to be in the 5%. So I think our strategy has been whatever delivery system you prefer, transfemoral, transcarotid, we're invested in both and plan to deliver both so that your choice of patient care or delivery to the patient and protecting the brain during the procedure is your choice, but ultimately the stent matters. So just a little bit of discussion on how that resonates in the market, your thoughts on it. Is that the right way to approach this, just in general terms?
We're well into the IDE trial, 3/4 of the way done, somewhere in that range. And we can't discuss those results, but I will say they're very good. And when all of us know that carotid stents, whatever you do there, if you do perfect protection, there's still a significant percentage of strokes that occur after the patient is off the table. Okay, whether you use TCAR, whether you use transfemoral, it doesn't matter. And that's from plaque extrusion through the stents. Now, it's small, relatively small, but it is there. And if 50% of strokes occur in that mechanism, and it's a 3% stroke rate, it's still a big thing that we want to avoid. This technology, the micro mesh or micro net, because it combines the best of both worlds. You've got a very flexible stent, okay? But on top of that flexible stent, you have this micro net that has the smallest pore size. You get the advantage of a closed cell stent and an open cell stent. It's flexible, it goes anywhere, and yet it protects against those late strokes. So I think given that, you've got a stent that 1 delivers very well, 2 performs very well. And as you said, Marvin, it doesn't matter how you get there. You want to do it from a TCAR approach, fine. It's the best stent. And even the flow reversal TCAR doesn't prevent those peri-procedural or after the strokes that occur from plaque getting through the stent within 24 to 48 hours. So now you've got a stent that's performing extremely well in a lot of our hands, that's doing well with the low stroke rates that we've all aspired to, as you mentioned earlier, in the 1% or 0.5% or so.
You've all inspired to.
Aspired to. Aspired to.
I have a note to say,
Tom, go ahead.
because I'm a fanatic of access routes and brain protection. I found the best stent I can use and I use it. So how can you get the results better with a better access route? So the TCAR experience is very interesting, but I'm afraid that as they're using a first generation open cell stent,
Correct.
their numbers will ruin the initial findings on the long run. And I'm afraid, or I hope that won't happen, that it will give negative impression to the stenting world per se. Because if you combine those data, imagine in a meta-analysis, you put those data in, you have an excess of late strokes, minor strokes certainly, but minor strokes, as they said yesterday, aren't that minor. They can influence your life negatively. So the important thing is you put the stent with the right protection system, but you put the right stent in.
Exactly.
I mean, TCAR has shown it scales quickly. It doesn't have a big learning curve. But if you look at one of the Achilles heel of TCAR is someone who's had a non-disabling stroke who gets a carotid stent, it seems to have a much higher stroke risk than carotid endarterectomy and transfemoral carotid stenting, probably because you have active plaque that's been breaking off. And, they probably continues to extrude through the open cell stent. And so, that's why if you have the best of both worlds where you can deliver it however you want, I think, it bears, witness to sit there and say, hey, if I have a stent that has flexibility, but also has extra scaffolding in that net to help protect against that, it probably would improve the one place where TCAR is shown to have some concern.
And as to your point, we're all fanatical about protecting the brain. All right. So if I use a lot of proximal protection or a combination of proximal and distal, what I tell folks, this is like a triple layer or third layer of protection, because if it's, whether it's TCAR, whether it's transfemoral, whether it's proximal and distal, you're now adding a third layer of protection before, as you stent and as you post-dilate, which is, as we know, the number one time that there's a stroke during the carotid stent procedure is the post-dilatation. Now you've got this tiny little micronet protecting you when you put your balloon in. So it's an extra layer of protection.
Actually, it's a great comment. You have proximal, you have distal, and you have intra-stent protection.
It's a triple.
You actually could say we offer intra-stent protection.
Well, for the first time, we have a therapy that actually attacks when I'm done. So I left the procedure and my patient's fine. Till date, we've had nothing that addresses that period after then to the next 30 days.
And Dr. Siddiqui was able to join us here.
Dr. Siddiqui, hi, how are you?
Hello.
I'm sorry,
Good,
I'm
that's great.
late, and I'm also sorry that I'm not there with you guys. Could have avoided if we have a big snowstorm coming in tonight, apparently.
That's what we hear. So thanks for joining the call. Appreciate you being here. So the setup was pretty simple, which is it seemed like a great opportunity during the VEITH symposium to revisit our initial KOL discussion back in March. Thought it would be a good opportunity just from the InspireMD perspective to be able to present our thought leaders and leaders in the field. Maybe it would be just a good chance for you to sort of revisit that discussion several months ago and share any thoughts or updates relative to your point of view as it relates to evolving technology, market changes. You've obviously had the opportunity to use the CGuard in our ongoing CGuard Against trial, but just in general terms, I think this is intended to be an open discussion about the carotid space in general and where we see things evolving, and maybe make mention to some of the work that we're doing in the tandem area as well.
Well, the gods of carotid intervention are sitting in front of me, so I'm going to not do anything where I might run afoul of their expertise. So I'm going to sort of talk about an area which is near and dear to my heart, which I deal with on a regular basis, and that is truly symptomatic carotid disease. Honestly, a real stroke that comes in with a large vessel occlusion or with a medium vessel occlusion, but with an additional either carotid occlusion or a critical carotid stenosis, where you say, well, I probably should fix that before I go north. I don't want to leave that alone. And so in the symposium yesterday, where most of us were there was this discussion about how much you need to delay before you treat the carotid. And, with tandem occlusions, there is no delay. You actually treat the carotid first and then deal with the stroke. And we have had just phenomenal results doing this for patients. And in the randomized trials that were done outside the US, where they did include these patients, there were 20 to 30% of large vessel occlusion. So these were big numbers. And so in all those instances, people were doing something to the carotid. There was a little bit of hodgepodge in those randomized trials. Some were just doing plasty, some were stenting, some were just plasting with the guide catheter going above. But what we have been systematically doing here in Buffalo is that when somebody comes in with a symptomatic carotid with a high enough NIH where the patient is in trouble, and I'll define that, NIH of 5 or 6. And then you've got to look at, is this carotid occluded? And if it's occluded and they have a perfusion deficit, even if they don't have a tandem occlusion. So this is those people who have an incompetent circle of Willis. So these are people who are symptomatic with a carotid occlusion, NIH 6, 7, 8, 9, 10. Those are the ones that fall into a category where I think they should be stented. A second group is true tandem occlusions, where the carotid is occluded and the M1 is occluded on top of that. And then their third group is where the carotid is severely stenosed, typically 70, 80, 90%, and they have something distal intracranially, which needs to be fetched, M1, M2, M3. In all those categories, we have been systematically treating these patients with an upfront load with aspirin and ticagrelor. We have sort of moved away from Plavix for 2 reasons. One's because in the neuro space, we have a 20-30% resistance, which results in thrombosis with intracranial stenting. So we just, by definition, because we do a lot more intracranial work, we just have moved to Brilinta, where the resistance is very rare. The other thing I like about Brilinta is that it's a 30-minute load, peak serum value. So I think that makes life a lot better than a 4-hour Plavix load. And we bring them up to the cath lab. We use a balloon guide in every single case, 8 French with a balloon guide. And we don't do a separate balloon for the external. And the reason we don't do that is we actually did a study. I think some session with some of you there where I actually shared that, where we have done about a dozen cases now. We do these Nova signal Dopplers on both sides. And the moment the balloon goes up, flows reverse intracranially without external occlusion. So what we do is we inflate the balloon after we do a roadmap, open the TUI, so we've got back bleeding. There is no concern for distal embolization at that point. Cross the lesion, plasty, stent, and then go up north. And in my mind, when I think about this, this is the most severe form of symptomatic carotid, and I wish we had the C-guard, because I believe that really would be the best stent in this acute state for 2 reasons. One, it's got a much lower metal surface area. So, you think of other cover devices, you think of the Casper stent, it's got almost a 40% metal surface area. And we have had acute stent thromboses that have been reported because the need for dual antiplatelet therapy is so much higher for that stent. Scaffold is off the market at this point, so otherwise that probably would be reasonable as well. And so I really think that the C-guard stent with its fine plaque coverage, low metal surface area with less need for aggressive dual antiplatelet therapy, never have to give integralin, by the way. Not once do we have we given 2B3S for carotids. Really is the best stent. So if you all would help me push Marvin so we can submit the IDE to the FDA. We're all gung-ho about it. I think that's what we need to do. And there is no competition there. There is no label there. I really feel that, you all can really sort of lead the charge, and we all know about the national coverage decision. But I think stroke is a wide open space that will bring incredible value. And I honestly feel that this is the best stent because it allows to deal with tortuosity with its open cell design, and it allows to deal with plaque prolapse with the mesh. And I'll stop there.
Great. Well, thank you for that. And we're actually sending a contingent to Buffalo tomorrow. So you'll be happy to know that you don't have to push me. So we're coming quickly. We heard you loud and clear, and we think this application for C-guard is certainly one that we're very interested in and offers really an optimal scenario for the design that we put into the stent. So just back to a couple of quick questions, and maybe we'll just kind of take this to more of an open discussion. Dr. Mesker pointed out early in the discussion it's all about positioning and timing. So as you think about the carotid space over the next year or two, relative to reimbursement, other things that are happening with technology platforms coming to market, the continued evolution of TCAR as an application, including our device and other things. How do you think about how this transition from surgery to endovascular care looks, in the short term, medium term, and is this finally going to be that moment where everybody's expectations are met and we don't have to put a chart up anymore that says all the other vascular areas have migrated from surgery to endovascular, with the exception of carotids? How does that feel from that perspective? And then maybe Tom can share some points of view of how things really operate in Europe in a European perspective. But
I'll start just because we're going around this way, but I think it's a nice spot, certainly for CGuard and some of the others, because of the stagnation which we already talked about. The companies that have carotid stents right now are old technology. You think about the Acunet, for example. I haven't used one in 15 years. They're still around. We have just a couple stents, and there are a couple relatively decent stents, but even some of the bigger players have old stents that none of us like and none of us use. Okay, won't name them, but they're there. So now, moving forward to a time of reimbursement opening, it is an awful good time to have a new stent with new technology, some of the features that we've just talked about that give you conformability and coverage, and the results that will be, I think, I predict, as good as anything we've ever seen. So it's a very exciting time. I think, quite honestly, Marvin, for InspireMD and for folks, just because you're in that house of having all those things in competing against stents that are 20 years old and haven't changed in 20 years. And if your stent plays well, now no matter how you get there, whether it's from the TCAR approach, fine. Put the best stent with the TCAR if it's best. If it's from transfemoral, transradial, doesn't matter. You can get the stent, you have a stent that works. I think it's an exciting time for those. And I think some of the big companies are going to be scrambling to get back in the game, would be Chris's prediction.
I like that.
I agree. I mean, there's some big strategics who spend a lot of time investing in space and do not have a product in the space right now and have not. But as we talked about, if you decided to start creating a technology again today and nobody's improved stent technology, there's not been a new stent on the market since I can't remember when. To start, it's 3 to 5 years at best, and hundreds of millions of dollars. And so, you're going to have a new stent with new data. It's a new platform. It delivers something new. All of a sudden, when there's going to be a rapid rise in demand, and I think that's a great time to sit there and be there where you can stand alone. I'm sure there will be plenty of big strategics coming to talk to InspireMD to sit there and say, well, hey, we missed out. We've waited too long because we weren't sure what's going to happen. But, I really feel that, with the 10-year data being so strong, showing that if you choose the anatomy appropriately, you can have excellent outcomes with whatever approach it is, whether it's endarterectomy, medical management, TCAR, or transfemoral stenting. And I think we're starting to see that. I think, one of the issues we have with stenting is calcium, and we're seeing therapies now we use in other areas of the body for calcium. I think we're going to see a rapid rise in investment in the carotid space to help not just what we know we can treat well today, but hopefully to start tackling some of the lesions where we know that, the current stent portfolio doesn't work well in a densely calcified lesion because we can't get the calcium to yield. And I think we'll see therapies that might start getting adopted that may help that actually broaden the amount of patient population that have equipoise in their choices. You'd say, okay, you would definitely do surgery now. And you can say, all right, now if I can address getting the calcium where it will yield, now it's a patient choice. It's patient-centered decision-making.
So in general, the carotid narrative becomes important across the board.
Completely.
That's kind of the message, is you have to be at the right place at the right time, as you said, and make those investments.
As the older guy here, I can see the population is not getting any younger, and it actually is aging. And to that point, to Sean's point about it's aging with more calcific plaque and more challenging plaque. And I think we need the technologies like this to be able to manage those kinds of complicated patients.
Right.
I constantly am impressed by some of the stents that you all have put in Europe, and looking at Piotr, for example, and some of those lesions look so ugly, and they came out beautifully with this stent, which you wouldn't do. I mean, so I think this stent is an enabler to allow you to treat patients who might not otherwise have been treatable. And to Adnan's point, that includes the recently fresh clot, things like that. We have to do develop the evidence base for that, but I believe that the covering will actually facilitate and protect the brain, as you said, even better.
So I'd like to just maybe get Tom Castrucci to jump in here, just a little bit of European experience, because you've had CGuard approved now for the last 5 years, and it's your go-to device, and it's maybe a little bit of a different market, a different perspective. But Dr. Siddiqui, before you leave, I want to make sure to get your thoughts before we wrap things up as well.
I've got a question, Tom, too, is that in Europe, how does CGuard stack up? What is its market share, and what can we all learn from the fact that it's out there competing with these older stents? Where is it doing well? Where is it not doing well? And then Marvin, it's for you. Explain that to us.
So I've got in my shelf, I've got 3 types of stents. Can I name them?
Of course.
I've got Casper, carotid wall stent, and CGuard. So Casper, we call it Road Saver in Europe. Wall stent, I think they'll all go back to the producer. We don't use wall stent anymore. Casper is used very, very rarely, because I don't like the maths you've got to do to understand how long it will be. So my first choice stent is CGuard. And the people I talk with, my colleagues who practice stenting, use CGuard. So I think CGuard is for all the reasons you just said, it's flexible, it contains the plaque. It not only contains the plaque, but it contains ulcerations as well. I've got some cases in which in the final angiography, you see the dye that remains in the ulceration, and the emboli will remain there as well. So with a first generation stent, that would be an embolizing issue, and a profound ulceration. And when you talk about calcification, I've been to a meeting lately, and they started using these special balloons to fragment the calcified plaque. You feel quite confident doing that with a proximal protection, because I imagine that could generate quite a lot of debris. So calcification will not be an issue in the future, in the near future. So the difficult question is the one Marvin asked at the beginning. What will the transition from stenting to from open surgery to stenting be? Why are vascular surgeons some way allergic to stents? At least in Italy, in my group with 10 surgeons, 3 of us use carotid stents, 7 it's against their religion some way. Okay.
Yeah, I think TCAR has sort of changed their approach, really. It has opened up, and now TCAR is rapidly growing. I mean, they went public based on widespread acceptance by vascular surgery. But CGuard still doesn't have the lion's share of the market in Europe, does it, Marvin?
Yeah, I think, we see our market share across the board. It's somewhere in double digits, depending on the market. In Italy, it's the bellwether for us. We think that we have about 36 to 37% of the market. There's sort of 2 things pulling on that. One of the economics are very different, right? It's a DRG based system. There's a lot of tenders that are created. It's not a favorable environment, nor is it evolving into a favorable environment for innovation. I mean, the reality is that it's just not, it doesn't reward innovation in many ways from an economic perspective, but we compete and try to compete on that level of data. We've got 5-year data now on CGuard. We're 36,000 stents into our sales overall. So it's a really important topic for us, but I think it's a very, very different market. But part of our investment in a TCAR delivery system with SwitchGuard is really for that purpose, because right now we play in a total market in our served markets of about 40,000 CAS procedures, right? When there's about 290,000 treatable available. So we're still trying to climb that wall of surgical conversions to CAS, right? I think we do well in the smaller sandbox, but we got to make that bigger.
So I agree with Adnan that I think the allergy to carotid stenting has been mitigated a bit by TCAR, and so to that we owe TCAR the delivery of the acceptance on the part of many vascular surgeons where before they weren't. I mean, I can speak to some at Mass General who were absolutely allergic to stenting and now are embracing stenting using TCAR. But I think that will also that means stenting's okay, and leaving a metallic implant is okay. And now that's generally much more accepted in the carotid. They've always accepted it in the abdomen and the pelvis, but now it's okay for the neck as well. And I think that's going to play. The other thing to say is in Europe, my understanding, and I don't know the data, but your sales are increasing.
Yeah.
And I think the market share is gradually increasing. I think the momentum and the excitement that happens when CMS, hopefully, when we sort of move to the next level, will actually enable a rise.
And from the investor standpoint, I would say there's a difference in the European market. And let me explain. Not any, but they're willing to use a wall stent in Europe for some reason.
Right.
I want to ask anybody at this table who does carotid stenting the last time you used a wall stent. They're not on my shelf. You need a slide rule to calculate how long, where to put it. All right, and one, but you're not in this room, Adnan, so give you a hand. The bottom line is Joe America is usually not going to use a wall stent. Okay, and and the reason you now use it now, Adnan, number one, you're very skilled and you can figure out the slide rule that I can't. But you need closed cell coverage for some of the plaques that you treat. Okay, so when you have this stent available, your wall stent, my prediction would be, okay. And as mentioned earlier, unlike the Casper as well, or the Road Shaver, whatever we're going to call it, we were in that trial. We put a lot of people in that trial, and it would go this long. So you didn't know how long it would end up. A CGuard 30 is 30 millimeters long. By the way, a CGuard 40 is 40 millimeters. The math is pretty simple, even in Tennessee. So the point is now.
Not that difficult. It's not that difficult, Chris. You just look at it and you kind of say, that looks like an 821 to me. It's not that difficult. You just got to close your eyes and feel it. What's wrong with that?
Very
so
scientific.
This is the one of the world leaders here for the investors telling you the method of preparing.
We won't write that into the IFU, okay?
You do this and you just kind of put it together. So the point is,
I'm sure he's never said that to a trainee. Just close your eyes and feel it.
I've been up there as a trainee up there. I can promise you he never said anything close to that. But the difference in the Europe is that they are willing to do a wall stent in the marketing in the DRG. That it's a little different. In the United States, we're not going to use a wall stent. We're not going to use some of the others, and the other older ones. This new stent will compete extremely well again.
Right. So I think in general, Dr. Siddiqui, you pointed this out. In general, we have to hold a higher standard and we have to create a different standard. And we're trying to do that with CGuard. And that's difficult, right? Because, when you're playing at a certain level, an expectation of a carotid stent hasn't had the greatest reputation over the years. And so when we work on data and we have 5-year data now and 1,850 patients enrolled in studies, we're trying to set that new standard of care expectation that 1.1% complication is what you should expect, not somewhere between 5 and 7 and hope for the best. And so, that's a tough one, frankly, in the European setting, because many times cost of the devices becomes the driver more than, you know, is
But
it
you
really
hit the
best?
market with, for the US market with a head-to-head comparison against a legacy stent. Whereas, you know, in the endovascular arena, there's so, except for the coronaries, there's so little head-to-head comparisons. We've seen a few in the lower extremity in the last couple of years, but for the most part, there's zero. And so, you know, we've already seen where we can go with the current technology that's available to us today. We've seen with what's been reported for the Sea Guardians to be improved, and I think we've all seen it as part of the trial in the cases we've done. But you guys have head-to-head data comparing two devices, one commercially available in the United States and one, you know, the Sea Guardians, and so you already will hit the market with some data to speak, saying what's the difference between the old platform and the new platform. And there's nothing we have today, say it over and over again, after I close the groin or I close my neck for TCAR, I have nothing after that point when my patient wakes up to protect them for that stroke that happens between that point and 30 days. And this does, I mean, it also helps with the intraprocedural plaque. So it's helping on the two areas we know are the most highest risk. We have nothing that hits the whole second half of that equation.
Great. Well said.
But that's the origin of the ACS2. Says that stenting, everyone knows what ACS2 it says, but it's considering tens of different protection systems.
Or very
Ancient
few, or
stents.
27% of people use the protection system of the 10 different ones, for crying out loud.
Yeah,
Yeah, but
okay,
anyhow,
and different stents, open cell, closed cell, double layer stents, and the results are comparable to surgery. I wonder if you use the best protection system or access route and
The best stent.
the best stent, what will the results be?
We're thrilled that you guys are believers, and we'll continue to work our hardest to make sure that we honor that, and that we go forward that way. Dr. Siddiqui, any final thoughts? We know it's getting late in Buffalo. You've been traveling. Well, your flyer miles are all
I need to get my snowmobile out tonight, maybe. But you know, one question I have is for, you know, Tom, with your experience, when do you think this is not a good stent? And I'm not talking about a heavy calcification environment right now, which hopefully with things like shockwave and other technologies will also become, but leaving that aside, you know, is there a situation where you say, I probably shouldn't use it? Or is there a drawback to this technology that we should be aware of?
My religion forbids me to give you an answer. So yeah, there is. It's the very tortuous access route.
Okay.
Very tortuous access route. I expect with the new delivery system, this issue would be addressed. But very tortuous common carotid, type 2 arches, type 2 arch, tortuous common carotid, you'll have quite a lot of friction in the system. And but that's a drawback for the stent, but not necessarily a drawback for stenting. Because if you think you want to treat that patient with a stent, in that case, only in that case, you can use another stent. The important thing is it won't have the same outcome in time, it probably, but you're in a situation in which you've decided that that patient is a high-risk patient for surgery, okay? So you've decided that patient needs a stent. You can't do, or at least the cut down would be at too high risk. So you've decided you have to operate him. You have your CT scan, your pre-op CT scan. You know it's going to be very torturous. You can choose something else. But your mentality tells you, I want to put a stent in that carotid artery. So that's what's the most difficult thing, I think, is for you to convince the vascular surgeon that there is an option for stenting.
So with the new system, would that make it more favorable for such tortuous anatomy as well?
We hope so.
We hope so.
The new transfemoral delivery system called Seaguard Prime, Dr. Castrucci has seen it. Actually, we're all going to see it this evening. It's built on a very different platform and delivery handle and flexibility of the shaft of the catheter. So we hope that that addresses that situation and makes it more usable in acute situations in particular. So that was the investment in the transfemoral side. And then of course with TCAR, with SwitchGuard, to the extent that you want to choose a different route. We'll even hear tonight a bit more about from Dr. Castrucci about his innovation with using a Stryker flow gate balloon transfemoral reverse flow, which is
But Adnan said very interesting things. I love what you said about version with common carotid artery clamping.
Yeah, it's no need for external balloon. You
No
know,
need.
we used to do MoMA, but the problem with MoMA and stroke is that you can't get intracranial with anything big enough. So you got to take MoMA out and go back up with something else. And so with an 8 French balloon guide, we did TCDs, but I'm a strong believer in proximal protection. This guy, Chris, brought me into the fold with MoMA, but I think now that fixed ratio restricted lumen with MoMA becomes a problem with, you know, tandem intracranial stuff. So we've just gone.
And another thing, the tortuosity issue, it happened once in 180 stenting procedures. So it's,
When you say it happened, it was a non-deployment?
it was a non-deployment.
Yeah, but no harm, but just you.
No, I just took it out and I think it was.
But assuming you're doing 6 French, and with Adnan, he's using an 8 French loop guide, which is not going to have that issue because you have a bigger inner lumen.
Right.
Absolutely. 8 French. And the other thing I have to tell you with the balloon guides is in tortuous access, it becomes a real godsend. So flow gate is not really very good. It doesn't deal with tortuosity well. We use this balloon guide, Walrus, which the new balloon guides. You inflate it wherever it is, and now you can put your distal access catheter and wire and really, you know, it really locks it in. So I just love balloon guides for carotids now.
It gives us stability as well.
Yes,
Chris.
exactly.
Dr. Siddiqui, thank you. Thanks for joining us.
Thank you, guys.
Wish you were here. Next time we'll save you a seat.
I hope he'll be buying you a nice dinner at least.
We will. We'll send you pictures. But thank
Dogs.
Send us pictures of your snowshoes.
yeah, send us
I
this.
will. Bye-bye. Thank
Thanks
you.
for joining us. Guys, just any last minute comments? Thanks for doing this. This is it's really important.
Exciting time.
We're often asked, whether it's by the investment community, Wall Street, our physicians in general, you know, is this the right time? Does this feel right? The ecosystem of medical devices operates pretty predictably. You get companies that are out in front of these technologies that invest a ton of money and time and energy, that are very specialized. Big strategics count on that ecosystem working. Sometimes it works out for reasons that have nothing to do with technology, that are all about wrong time, wrong place, wrong reimbursement. This feels pretty good to me, but again, we have to keep doing all the things right. And
I think we're at the right time where there is an insurmountable amount of evidence. CMS could not, in my wildest dreams, not overturn the NCD and basically leave it up to clinicians. There's 10-year randomized data. There's you know, level 1 evidence.
And I think, you know, for the investors over in the call, there's timing, and this timing is good. When you have a product that's good, a timing is good. And then I would say from the physician standpoint, you know, honestly, when you put all that together with a company that people like. So the CEO, believe it or not, this guy's a likable guy. You can see on the screen, but everybody on, you know, from our first trip to your fine town of Rome, you know, and meeting the entire company that's worked so hard on this, they are phenomenal people. So when you have a good company and a good product and a good timing, I'm excited, you know, and so good.
thanks, guys. Thanks for your time. Let's take this meeting to the next venue.
To the next level.
Awesome.
Thank you all.
Thank you.
Thank you.